few minutes. I don't know if you were following HCIFS at all, Katie, but they started even later than expected. So as long as it's okay with all of you, I just want to see if we have a few more people, then I think we're probably going to have folks kind of trickling in throughout the meeting, but we'll see if I can get a couple more and start.
Sounds good. They did just wrap up with the votes, so.
Great. Yes, I was over there for as long as I could be and then hurried back, but they're doing the commission report next on that market oversight. The full title is much longer, but the commission that was meeting. So I know at least Trevor's probably over there for a bit. Kate and I'm guessing maybe as well. Give it maybe one more minute. I think Maureen was planning to join. I know Amanda Rector was maybe going to, excuse me, Amanda Burgess was going to join us remotely potentially. So I'll just give them one more minute. Oh, hi, Maureen. Great. So it looks like we've got a reasonably critical mass for such a busy and hectic day. So I can just jump in and get us started. I noted by email, I know that we're at a great moment where we're getting close to having a full complement of members again, which is really exciting. Both members were sort of approved by the committee who had confirmation hearings earlier today that I just came from. So good news there. So they'll go in front of the full Senate, I think, to make it fully official. But I think we can probably be reasonably certain that both Amanda and Richard will be confirmed. So exciting there. And I do, given new membership, want to take some time and sort of have a full set of introductions and a little bit of level setting. But given that we've got a lot of kind of folks coming and going today, and I think they're going to be trickling in, I think we'll hold and try to do that at the next meeting when things are a little bit more settled. And Amanda and Richard have had more than like 15 minutes time to adjust to being confirmed. So I'll jump in with other business. Just on the agenda, actually, I guess I don't have too much to say. I'm going to be handing it off to Katie. She's got a couple of updates on analytics work that we sort of talked about at several meetings from spring through today, both the data refresh on some of the existing dashboards and then the progress on the professional services dashboards that we've been working on. Then I wanted to spend a little time talking about the Rural Health Transformation Program and the role that it looks like the Office of Affordable Healthcare is going to be playing in that program. And then finally touch on some developments and additional work on the legislation that we discussed last time we met. I'll hand it back over to you, Katie, and let you jump in.
Absolutely. Good afternoon, everyone. As Meg said, I'll be providing an update on our analysis plan that you can see here. Today, we'll be discussing some progress we've made on our dashboards. Over to the left, we've highlighted the two we'll be talking about today. So it'll be a refresh on our hospital payment and utilization dashboards that we put together last fall. And now we've refreshed with new years of data and an update on the progress for our professional services payments and utilization dashboards. So just as a quick overview, and happy to go into more detail with new advisory council members or refreshing for existing advisory council members on kind of the data behind all this. But as a brief overview, we've been working with the Maine Health Data Organization to create aggregate hospital level dashboards to measure payments and utilization across hospitals in Maine. And really the purpose of this was to try to identify and describe variation in payments and utilization across Maine's hospitals and for select services. And the metrics we show are total payments and then payments per unit, and total utilization for three groups or categories of services. Those are inpatient, outpatient, and professional services occurring at hospitals. And then we also have some information on select services, total payments and payments per unit and utilization. And the update here from our last round of dashboards is that we were able to include 2 data years, 2023 and 2024, which brings us a little bit closer to understanding, post COVID-19 impacts and trends on payments and utilization. So what I will do today is I can actually drop into these dashboards and do a little bit of a refresher of what these look like for everyone.
Bless everybody. Always takes a moment when you're shifting between different ones.
All right. Here, move these boxes around a bit. So here, these are what our dashboards look like at this current time. They're not on our website yet, but we're hoping to put them up in the next week or so. We're just finalizing the last kind of formatting of these dashboards here. But we have an overview tab that will show our payments and utilization over time. And down at the bottom, you can see that our years now go from 2018 to 2024. And what you'll be able to do here is click on a variety of payers and payer types. And then on the right-hand side, you can see our service type. And then we're able to click into payments, for example. And here you can see, here we show payments per capita over time for hospital services across different payers. You can click the all button here and just choose a select number of payers to look at. And then on the right-hand side, what you'll see is year-over-year percent change. So these are very similar to the newest dashboard sets we have up, but we're excited to have these 2 most recent years of data to really understand how trends are continuing in more recent years, again, post the impact of COVID-19. We'll stop sharing there and can move on to our next set of dashboards.
And while you're doing that, maybe I'll just say as kind of an update on the longer term, what we're envisioning is this being kind of an annual process where each year, as there's a new year of data available, that will sort of update and drop the oldest, the furthest back year from the data set. We had some conversations about that and how helpful is it to keep retaining years, but I think especially right now, given how sort of disruptive and unusual the period around 2020 was, we felt like moving through and getting several years of data, kind of excluding those years, is the most maybe helpful thing to do. And then we already have obviously so many data points in these dashboards that we're not overwhelming folks with years and years and years of data. So just thought I would say that this is something we kind of envision being an ongoing kind of maintenance, I guess, of the Office of Affordable Healthcare to kind of keep these dashboards up to date for users who want to.
Absolutely. And then our next update today, see if these will move on. Here we go, is looking at our non-hospital setting type payment and utilization dashboards. So our first set of dashboards really focused on services occurring in main hospitals. And our next set of dashboards will be looking at services that are occurring in the outside of the hospital setting. And really here we have a similar aim to identify and describe variation in payments and utilization, but in the non-hospital settings. And we'll be able to provide metrics like total payments, payments per unit, and utilization by both payer and then bill type. So whether it's an institutional bill or professional bill in these settings. And we also were able to work with MHDO to put these together and include the years 2018 through 2024. Today, these are still in development. We are working to get through a couple more methodological decisions, but are making progress and hoping to get these out as soon as we can to share with you all to give a look at what these look like. But today, I wanted to take a couple minutes just to describe how we've come to put together the non-hospital setting type classification. So non-hospital setting types what the MHDO team and their vendor HSRI do first is look at the actual code, the type of bill or place of service code that comes in on the submitted claims. And what you can see to the right here is we have a table of the non-hospital setting type categories that we put together. I'll highlight that the two in blue, the office setting, primary care, and office setting other, are not mutually exclusive from these other categories. They take from these other categories because we've had specific interest in understanding payments and utilization across these categories. And then I also just wanted to note that we know this is not an exhaustive list of non-hospital settings. Specifically, we excluded long-term care from this analysis for a variety of reasons, but given the coverage differences among payers and data availability, we excluded them, though we understand that this is an area of great interest and we hope to dive into an analysis in the future. They just won't be included in these specific dashboards. And on the next slide, I can show you, kind of a thought in the specific categorization and codes that go into each of these non-hospital setting types and how they're being sorted into each setting type based on the claim that comes in. And today, I think that's just the overview that we wanted to do, but wanted to provide any thoughts, comments on this, and we hope to be, getting these out to you as soon as we can.
Yeah, thanks, Katie. And while folks are digesting, I'll just say, otherwise, I think the structure and methodologies of these dashboards are very similar to what you saw for hospitals, thinking about these elements of utilization and total payments and payments per unit. But that's why we wanted to focus, I think a lot of the work that's gone into this with our team, but with a lot of assistance and input and feedback, of course, and legwork by Karen Lee and the team at MHDO was thinking about what is the right sort of classification system here, what are advantages, disadvantages, what is possible with the data that we have where there's a good level of confidence. So just to flag, that's kind of why we wanted to focus on this, because this piece about classifying non-hospital settings is really kind of the new work in these dashboards, whereas the other elements we've discussed more extensively. Yeah, Katie?
Thank you. Ton of work has gone into this, and I appreciate that. I ran these past our billing people, and there are a couple, actually a few sort of what we would consider errors in this. So just wondering, we can take it offline, but do I work with you, Katie, on that, or how would you like to proceed?
That would be great. Feel free to reach out, and would love to chat about that, and especially if you can bring in like the specific
I've got them
that your team has, that would be great.
Yep, we'll happily do that. Thanks.
Okay. Well, yeah, as others are digesting that too, similarly, if you have feedback or have folks that are more kind of in the weeds on claims data analysis and want to send us any feedback or have any conversations, we welcome that opportunity. I'm sure we'll loop in the MHDO team because, of course, again, a lot of this is drawn from their expertise in working with the data, but welcome that now. That's why we wanted to share it so that we can get some early feedback and see if there were adjustments needed. Perfect. So then I can take over. Sorry. That's good enough. I can scoot them all. I wanted to spend a little bit of time talking about the Rural Health Transformation Program. I know I'm sure many of you have heard a lot about this in other settings. I know I mentioned it briefly as something that we were kind of involved in some conversations about through the application process. So I apologize. I think some of this I'm sure will be repetitive for many of you, but I just wanted to start with kind of the basics for those who may not have had sort of as much exposure or heard as much about this program. But the Rural Health Transformation Program was part of the big federal bill, HR1, that was passed over the summer. I think important to say at a high level that that bill makes many other changes, as we know, which have very significant impacts on Maine's healthcare system. As you see here, DHHS has estimated a loss of $5 billion in federal healthcare funding over 10 years from that bill. So acknowledge that that was the broader context in which this program was created. But it is a program that was created essentially as a grant program to states to provide funding to address rural healthcare. And there's some information about the funding structure here, but I won't spend a lot of time on that because sort of the new piece of news that came out last week was that Maine has received its announcement of its award for the first year of the program, which is about $190 million. Mix of elements considered some baseline funding and then sort of a competitive application program for the state. But that is going to be the award amount for the first year of the program. To say a little bit about the federal goals, and again, I'm moving very quickly. There's much more that I could say about all the elements of this program, but I think we need to do too deep a dive. But again, in case folks haven't heard, these are what the federal government wrote as kind of their goals for the Rural Health Transformation Program. Won't read through that list, but I can say, I think the federal government was very clear in wanting to structure and position this as a program of one-time funds that are intended to create programs that are sustainable beyond the end of the 5-year grant program. I should have said it is a limited 5-year program for states. So they were very sort of specific and directional about wanting to make sure that states, weren't using funding as sort of a temporary patch to fill gaps necessarily, but trying to think about what are kind of more structural changes that can bring about better stability for rural healthcare in the long term. There are some very specific kind of restrictions on use of the funds. One large one that I will call out is that funds to healthcare providers to kind of cover the cost of providing healthcare services was capped at 15% of the total award. There was also a cap that the Fed set on the amount of funding that could be used for capital projects. I believe that's 20% of the total award. So very specific kind of requirements around that states were required to comply with. List here of approved ways of using the funding. So as you see, transformation of care delivery, improved access, quality, and cost of healthcare, extended and enhanced services, but looking to make sure that there's not duplication of programs, and then technological and infrastructure investments. And that, as I mentioned, are sustainable beyond the kind of extension of the program or end of the program. So, I think the transformation of care and improved access to quality and cost of healthcare in rural America obviously has some synergy and cross with what the office is doing. So we were really grateful to be brought into the process of the state's development of its application. Just a couple notes here on, use of funds that were prohibited by the feds. New construction is one, not looking to create whole new facilities using the funding from this program. Clinical services that are duplicate billable services. So it was sort of clear that, again, you're not looking to necessarily be able to layer on an affordability program or add funding for services that are currently billable beyond what existing fee schedules are. And there were some other limitations as well. I should have said earlier, very aggressive timeline for this whole program. It was passed in the summer. Federal government had to turn around and notice funding opportunity by fall. States had a very short amount of time to put together applications, and then decisions were made very quickly after that. So a much more aggressive timeline than I think most of us who are used to working on federal grants or with federal programs are used to. And it also has quite aggressive expectations for sort of moving money out the door and working on programs. So essentially, if funds aren't kind of used within a year, there is some kind of run out timeline, but states will essentially lose funding that they don't spend. So there's really a desire that these dollars be pushed out quickly. So a little bit, and again, this is far less information. There is a lot more information available from the DHHS website. They're really the leads on this, and we're just sort of one contributing stakeholder with them. But I wanted to pull out a few highlights about Maine's proposal. They sort of summarized the goals of Maine's application as wanting to bridge the rural divide, really think about this, evidence about differences in healthcare outcomes based on geography and rurality versus the urban environments, and kind of addressing that with some public health programs and others. Providing seamless delivery of care, obviously workforce issues. I know we've talked about those a lot in this group, and that is something that is a priority of this program. and thinking about innovation and technology, where are places that potentially technology solutions could help play a role, where maybe physical infrastructure for the provision of care is a challenge. And then efficient incentive aligned systems. So really trying to think maybe creatively and in different ways about collaboration to provide services among entities or stakeholders that might not always kind of work together seamlessly, and then finding ways to structure payment for those kind of collaborative efforts that again can make sure that they are sustainable in the long term beyond initial funding. And the proposal was structured with 5 overarching initiatives, which I wanted to flag here. So the first is population health and promoting timely access. Second, workforce, called out on its own as a high priority. Technology innovation, access, so bridging the healthcare affordability gap for rural Mainers. This is one where we've certainly had some involvement, but that category of work contains a lot of those payments to providers that Maine did make an application to be able to do for things like uncompensated care, and also includes some work for the marketplace around kind of consumer decision support for the marketplace. But so we have some involvement there, but I especially wanted to call out Initiative 5, Sustainable Rural Health Ecosystems, which is a place where the office was kind of called out as having a role in the work moving forward. And that's thinking about addressing financial instability of rural providers and that component of thinking about what are payment models that support a different way of providing care that is more financially sustainable and works well for people. And within that sustainable rural health ecosystem, the terminology in this application is always interesting. There are initiatives that are kind of the umbrellas, and then the terminology used for the kind of programs or underneath each of those umbrellas is activities. So there's really 2 activities where, again, the office has been indicated as having a role. I will say a lot of this is still very early, having just received the grant amount. I know folks are, thinking about changes to the budget to reflect the actual award amount and things like that. But we've got 2 activities that we're expecting to play a significant role in. The first is improving hospital financial stability through tailored hospital financial management, planning, and targeted investment. So this is really thinking about working collaboratively with likely a cohort of hospitals. What the universe of that will be, we don't know yet, to think about financial stability kind of work plans and strategies, and then having an opportunity for some of this funding to flow to things like capital projects that are necessary to execute those plans. And I think we're involved there in large part. We've done some work thanks to this advisory council to some degree for trying to understand, how do we understand what cost drivers are coming into hospitals and, the different metrics for financial stability and what they mean. So looking forward to helping with that and having more to share, I'm sure, in the next few months. And then conducting rural regional health ecosystem planning and implementation. So this is an idea that I think draws a little bit on the experience that I know MaineCare is going through now with their transforming maternal health program, but thinking again about defining geographies and thinking about what are essential services that people need. We use essential services a lot, but I think trying to do some of the work to say, what services are those? What are the modalities for providing those kinds of services? Do they need brick and mortar? And if so, what kind of proximity do folks need to them? Are there different new technologies that can provide them in different ways or new collaborations? And kind of bringing lots of players in different geographic areas together to do some collaborative work to kind of design what a different way of providing care could be, or maybe it's the same way, but then thinking about, okay, if that's the sort of model of care that we want to see, what are the components that are needed to support that? I think especially around changes to funding models. So I see these 2, they're different activities, but I see them as interrelated and kind of complementary with that improving hospital financial stability, maybe being a little more immediate term, kind of stepping in. We know there are some hospitals that are really struggling in the state of Maine, so having an opportunity to work with them relatively quickly to make some immediate changes, but all of that with an eye to, in the longer term, again, sort of what's the strategy to moving towards a system that is kind of sustainable and self-sustaining. So That is just the quick overview. Again, I know it's still early and that there will be way more to share about this. And at some point, we'll definitely want to draw in other colleagues who have been even deeper, sort of been more involved in all the planning for the overall rural health transformation program. But I'm sure it is all going to be moving very quickly as up until this point. So I just wanted to give a little bit of an orientation to the members of this council about especially these activities that we will have a role in one way or another. And again, more clarity on that in the coming months. So we'll pause there in case folks have, any questions or thoughts on this update. I'll say I know Maureen is on and given your role and work in other states. I know every state is sort of, again, working quickly and finding new ways of thinking about projects and structure. So definitely look forward to in the long-term collaboration. I know there's been a lot of that already, kind of states sharing ideas and talking about what's next for implementation. I know every state ended up receiving funding, which we expected, but confirmed now kind of with a corridor between, I think it was 145 and maybe 280 million or so, kind of depending on population and rurality. So we're all in the same boat and working through this. It'll be really interesting to see as it all evolves over the next year or so. Okay.
Meg, this is Maureen. The one other thing that I would just add, and perhaps others already know about this, but in talking with other states, NASHB has been informed that while the news about the dollars is available and out there, as you've highlighted, there could be some tweaks, is the word I'd use, that CMS may follow up with states and ask that states focus on certain aspects of their applications and prioritize certain pieces over others. And that kind of information hasn't been shared yet. So just to highlight that, and again, that may be something that others already know about, but I know it's something that a number of states are very eager to start working on this, very eager to start procurements to get the money out, but CMS has told them just hold for just a minute because there could be more information coming out about their interest in what states prioritize.
Good to know, Maureen. Yeah, and that's a helpful reminder, I should say, as we received the sort of notice of funding, but my understanding, again, with a little bit of arm's distance, because we're certainly not the point people on this, is the state revises its budget and resubmits to CMS for sort of final approval. And so maybe that's the point at which there's more guidance we may hear. But, I'll say, again, things were moving very quickly, but sort of during the exchange process, I think there was one question that the state received about the application. There wasn't a lot of sort of engagement or concern expressed. So we shall see, but hopefully things are kind of on track there. More to come. Okay, well, with that, I can move on to the last section of the slides that I wanted to share. Just wanted to give an update on, development of legislation, this idea that we've talked about at our previous couple of meetings, for addressing the second of our 3 areas of policy focus. I included this slide just in case either Amanda or Richard were on and weren't oriented, but I don't think that either of them are, so I can move past it because I think the rest of you all know this really well, but it was just, to give a little bit of a reminder that this is one area of policy focus, market oversight and competition, as I said. The commission that met on that issue is having its report presented over at HCIFS right now. So that's kind of a scope of work that we have been engaged in through that channel. And then I really see this rural health transformation program kind of being a bit of a path forward for that, aligning incentives to promote efficiency and quality. That's something where we've been talking with folks over at the department in particular, and had some conversations with others, both on the provider and payer side, over the last year or so, kind of trying to think about what's the right role for the Office of Affordable Healthcare in this and what's needed. And I think now the Rural Health Transformation Program has really kind of presented an opportunity where I think we can be involved there. I'll call out maybe in particular, especially for Kevin, not to put you on the spot, but others as well. I think given our background and a lot of the focus that we put on the commercial side, I think one role that we can hopefully play is trying to think about multi-payer alignment, for example, and as we're putting these models together, what opportunities are there to not just think about the government as a, first for maybe change in payment models, but are there ways that collaboratively we can work with other payers too to kind of make those models more sustainable? Again, lots of open questions there that we'll have to see in terms of, what guidance CMS wants to give, for example, about how flexible they would like to be about changing Medicare payment to support this. So that's a little bit in the longer term, but that's a place where I feel like our office can be a contributor or a convener or kind of a link between many of the folks, especially in MaineCare, who have been working on delivery system reform for a long time. So sorry, a little bit of extra background there. I said I wasn't going to give more, but it's a nice moment to just take a pause, I think, and think about where we are on each of these areas of policy focus, but then specifically this regulating commercial prices for healthcare services. Again, this I think is familiar, but I know folks have been in and out, so just wanted to take a moment and pause on this policy framework that I had shared with the HCIFS committee and this group, I think, at our November meeting, that really is made up of kind of these 4 components, I'd say. So starting with setting reasonable limits on commercial hospital facility prices, with really 2 elements making up that limit. The first is caps on outlier high prices at the hospital service level, and then the other being a cap on the growth of hospital prices over time on an annual basis. And those 2 elements avoid claim spending and sort of generate savings for payers and end consumers. And our goal is to think about 3 priorities for those savings. The first, of course, being reducing healthcare costs, thinking about providing some relief for families and businesses, investing in higher payments for primary and behavioral health care, again, we've talked a lot about in this group, and then changes to prior authorization that could lessen admin burden on providers, where there's been a lot of interest, but a barrier has always been that's going to raise premiums. So this is a little bit of an opportunity to maybe offset some increased premium cost with savings. So more to say, but yes, I'm happy to pause. Randy here, if you have a question or comment.
Yeah, just a quick comment here, maybe a question. Obviously, this is just, recommended at this point in time. I'm hoping at some point we're allowing hospitals to explain, inviting them to a meeting to explain, the details that they have to go through and how this type of a policy would be crippling to some of the hospitals. So I'm hoping at some point this is just a high level and that we are digging a little bit deeper into this to help understand a little more of the details than just saying this looks all good on paper, but realizing that most hospitals are dealing with government payers that represent 60 to 70% of their total business, and that there's only a small commercial payer mix. Unfortunately, that's how the economics kind of works in this, and capping pricing does cause some issues, especially when we're not capped on what our expenses are. With that, pharmaceuticals going up double digits every single year, or even the cost of food or the cost of labor. So there are this all sounds good in theory, but I think we need to know some of the details from the hospital's perspective as well.
Yeah, appreciate that, Randy. And there's a couple things I'd say on that. First, this is a framework that we have brought to the legislature, presented to HCIFS, but obviously this is not something that we have ability to move forward on ourselves. If it moves forward, it'll go through, a full legislative process and have full public hearing and all of that sort of transparency and ability for folks to weigh in. In terms of analysis and understanding impact, we've got a slide just a couple slides later to talk about the analysis that's kind of underway right now to think about what the level of these caps and floors is, because obviously that's a key component in understanding impact at an aggregate level, but at a hospital level as well. And so I think that'll inform the conversation and give folks a little bit of an ability to, understand in more detail. We understand we're not at a point where we have that yet to be able to share, but we are working towards it. And the other piece I'll just say, which we'll touch on a little bit later too, is, we have done some thinking, again, understand that there are some hospitals that are really struggling right now about how to account for that and create exemptions for hospitals that are in financial distress or financially vulnerable. So that is an element that we've kind of incorporated into the more detailed summary of the structure that I can touch on a little bit more next.
And just so everybody knows, I'm the former president of Inland Hospital, so I could express my concern about the financial strains on hospitals. Also, this more kind of I'm new to the group, so I'm sorry I'm asking these questions, but I wasn't able to attend the last meeting, and I was looking for minutes. And do we take formal minutes for these meetings so that if you miss it, you can get a quick summary of what transpired?
We haven't taken minutes. We post the recordings of all the meetings on our YouTube page, so all of them are accessible to go back and watch through, and then we always make the slides available after. That's something I'm happy to consider. I will say for about the first year that I was running these, it was only me doing them, so it was really difficult to take minutes and run the meeting and do everything. And I've always felt, for me at least, like being able to actually just watch the conversation, especially because these tend to be more conversational meetings. We don't often sort of move through an agenda of lots of official business. I usually like to kind of just listen in and hear the whole conversation, but I think if a majority of members, would find it helpful to do summary notes or minutes, that's something we can certainly consider.
Yeah, I mean, I've been on a number of committees and boards, and it's kind of traditional, and it is helpful, but I'll leave that for discussion and thoughts from the others as we move forward, if that would be helpful to have minutes. And is there formal votes and this is my last question, and I'll let you move on from this, but are there formal votes taking on something like this where we, what our focus is going to be, or what's the role of this committee? And do we have a certain percentage? If we are voting, are we looking for a certain percentile to move something forward? Just trying to understand the role of this group.
Yeah, so as an advisory council, we haven't taken formal votes in the past beyond some early meetings where the council, I think, adopted sort of a meeting, a virtual meeting policy, for example, and I think we officially did a vote there. We haven't generally sort of moved votes, largely because I think we've kind of brought ideas that are in development and asked for consultation. And I think especially in a legislative structure, it's difficult to find the right moment to say, is this yes or no? Right now we don't have a draft of a bill necessarily to share with folks to make a decision on. So we haven't done an up or down vote. There is language in the statute establishing the council that does say a vote for the council to take action requires a majority of members to vote in the affirmative. But again, as an advisory group and not a board, for example, where the decision-making authority is vested in the group, we've kind of kept things a little bit more informal here and consultative rather than formal decision-making.
All right, thank you.
Yeah, Kevin?
Yeah, Meg, thanks. Just thinking about this recommended policy framework, I may be jumping the gun, and this may be for later, but I'm assuming that this framework would only apply for discount off charges as opposed to any fixed fee or alternative payment methodologies. And in some ways, this could be, the alternative payment methodology could more easily result in the desired outcomes on the right without really needing to establish those limits, because within the framework of the APM, the goals and objectives could be met. So I guess it's kind of a loaded question, but wondering if this is more specific only to the discount off charges.
Yeah, that is right, Kevin. We're really thinking about kind of negotiated allowed amounts, I guess is the way that I would put it, though I welcome you have feedback on that terminology for me. it wouldn't apply for alternative payment models or any other kind of, non-fee-for-service, non-basic claims-based payments. And that is something that we've thought through and that I think is intentional. On the one side, in terms of reach of the policy, it's been our understanding, and from what we've been able to do using the data that's collected by MHDO and just sort of understanding with folks, I think the universe of payments from our understanding that are happening for hospital services in particular through alternative payment models is relatively small when compared to kind of more fee-for-service negotiated contracted rate. So those would be excluded and wouldn't be subject to this cap. And I will say I view that as complementary efforts, I guess, is what I'd say. And I think that that's where it ties into kind of the work even the office is going to be doing under the Rural Health Transformation Program. We're not saying that this policy framework is kind of the solution for all things in healthcare by any means. And I agree that moving towards real value-based payment kind of models where we're looking at payment for outcomes, for example, is important and necessary to do as well. But I'm thinking of this a little bit as, it takes time to move there, right? And that's been something that I know folks have worked on for a long time, but at least in the commercial sector, in terms of, the real volume, it's, we're not seeing a huge shift in that direction yet. So hopefully that, happens over time. And I don't think that this policy is a deterrent to that. I think it, in some ways, it could be an incentive to kind of move in that direction. So I don't see them, I guess, as mutually exclusive, but if that helps to answer your question about the scope, just from kind of a practical operational perspective, when you're thinking about using a relative rate as a cap for prices, you have to be able to make a comparison to a Medicare rate, and trying to do that for anything beyond essentially a fee-for-service payment is very challenging. So that would be the limitation on the scope of those limits on hospital payments. Does that answer your question? I'm happy to kind of engage more also, talk more deeply offline. And I'd also be interested in your reaction. I mean, I know you're speaking on behalf of one payer, but, if you have feedback on our perception, I guess, about volume there being wrong, would welcome hearing it.
Yeah, I mean, I'll save it for later, but you did address my question/concern, so thank you.
Yeah, Katie?
So I think I have a question now based on your answer and Kevin's very good question, which is how are you treating DRGs in this legislation or in this proposal? So
yeah.
that's, yeah.
Yeah, so the caps would be applied at a DRG or
Right.
At AP level for at the outpatient side.
So very importantly, that is not what I just heard. You had said fee for service previously. DRGs are not fee for service. So I think we just need to be clear about the nomenclature here and what it is you're applying this to. So that raises a whole nother set of questions, but maybe for another time.
I guess I would say, maybe it's shorthand. I tend to say Medicare fee for service, that traditional Medicare maybe pays on largely a fee for service basis, as opposed to under-structured alternative payment models where, we're still thinking about a claim and then a process of using DRG groupings to roll up those, individual claim line elements. So maybe it is terminology, and I'm happy to dive more deeply into that. But I think what I'm trying to differentiate is a payment based on, a set of services provided, as opposed to something where an entire category of healthcare is being sort of rolled up into a single bundle payment. For example, we're still talking about a payment for sort of an episode of care, but glad to dive more deeply into that. I can say, we've been working through this a little bit with a team of folks who are experts on kind of Medicare billing and billing in general. And I think, they feel like there's a pretty reasonable logic for thinking about the majority of claims and how to make the comparison to Medicare. And that's what I'm trying to refer to.
I think this particular discussion warrants a lot more discussion with individuals who have expertise on this topic, since DRGs necessarily cap the amount that we're paid as it is. So they're capped based on an episode of care. If that episode of care extends beyond that DRG payment, we're not paid for that. So it really is a risk-based model. And I think as you're proposing this and we're getting into the weeds, I think it's going to be important for this advisory council to have clear understanding of the impact that this proposal will have on payment rates for hospitals in the state of Maine.
Yep, and that again is why we're working on the analysis to quantify that at both the carrier and hospital level. Maybe I can move on. I'm happy to keep talking, but it does feel like a few of the additional slides are probably informative for the conversation. First, I just wanted to kind of share one with some updates from items that we'd flagged or talked about, moving towards the thinking about decisions on, but where I think those are kind of pretty firmed up and just provide those updates. So, we'd indicated, thinking about using Medicare prices. Now we've talked in more depth about that. As a benchmark, alternatives to that are really thinking about what averages or median commercial rates are. But as you saw when we walked through what other states are thinking about, it's generally much more common to use Medicare prices. I think it is simpler, and we do feel that Medicare rates are rigorously developed. There's a transparent process to sort of understand what the inputs are that go through into them, and then relatively easily available through public data files, which is an advantage as well. For a cap on growth, what we have been thinking about is using the Medicare IPPS market basket adjustment that is used to annually adjust Medicare payments under IPPS and OPPS. Some other states who have thought about caps on healthcare growth have used other measures like CPI or state level measures of inflation more generally. But I think hearing your point from earlier, Randy, about maybe unique inputs into the healthcare sector, we know that the market basket that Medicare uses is sort of designed to be more specifically tailored to hospital input costs. And obviously a lot of work and expertise goes into the methodology to create that. So I think it's an opportunity to utilize that, again, relatively transparent process rather than working from the ground up to create something and more tailored, again, to the experience specifically of the healthcare sector rather than the economy at large. For the scope of the service level price cap and exemptions, this is something else we've given thought to, and I think probably indicated in the past, we'd envision excluding all critical access hospitals from those service level price caps. And that does represent the majority of sort of the smallest and most rural Maine hospitals, few exceptions of some slightly larger rural hospitals, certainly. But at this point, I think we're close to having about half of hospitals in Maine with a critical access hospital designation that wouldn't be subject to those caps at a service level on the prices that they've been charged. And also including an exemption for poor financial performance or financial vulnerability. Thinking about measures that we've talked about a little bit in this group before, probably a combination of measures like total margin, operating margin, potentially cash on hand or age of plant, trying to think about what are a few key measures that are reported already to Maine Health Data Organization and are relatively well understood by folks to make sure that we are thinking about hospitals, again, to your point, Randy, that are really on the brink, that really are unable potentially to withstand any change in their revenue and to exempt them for a period of time. We would envision that not being forever, but as finances hopefully improve, maybe they would sort of move into the program, but to address and respond to concerns, which I think are valid about hospitals that right now may be facing some severe financial challenges. And again, goes hand in hand with the work under Rural Health Transformation Program. We know that changes need to be made, and we want to see hospitals sort of turn around and be able to move towards financial viability and stability over time. And we think there's ways to do that, but just feel like the answer to that can't just be higher rates for commercial payers. And then finally, primary care and behavioral health investment. We've been doing some more work to kind of try and define what the category of services that would be subject to the floor on payment from commercial payers would be, and are thinking about really focusing on evaluation and management, preventative services, and a set of counseling service codes. So I think I've said before, we know, again, following work with MHDO and others, that defining the whole universe of what constitutes primary care and behavioral health care can be very challenging. And obviously that's important work for tracking and monitoring. But we're looking to be a little bit more tactical here is maybe the word. And we're really trying to think about what are the services that represent the majority of revenue for a primary care practice or a practice or organization that's focused on behavioral health. So we've had some conversations with folks in those spaces and kind of landed on feeling like this is the universe where investment would make the most meaningful difference for them in terms of, you know, actually increasing their revenue and helping the financial stability of those providers. A note here, you know, we envision this floor applying to all providers, so it's not just a floor for hospital affiliated or practices or services provided in a hospital, but all providers, including independents. And an important note here, and I can get into a little bit more of this, I think maybe on the next slide, is that self-insured plan sponsors would only benefit from the price caps included in this policy if they also comply with the requirement to pay at least, you know, at the rate of the floors for primary care and behavioral health care. So just to say a little bit more about that, and again, I know this is very familiar for the folks in the health policy side, but we cannot mandate, we can't tell employers who offer self-insured health plans that they must pay at a certain rate for primary care and behavioral health care, which is always a challenge in thinking about state policymaking because that is the largest segment of the commercial market, and we miss out on a lot of folks. So we try to think creatively in developing the structure of this policy to say, this is an opportunity where we can maybe offer a little bit of an incentive. There's an opportunity that generates some savings here potentially for some of those plans and the TPAs that provide plans to them. And we want to use that as an incentive to do some good work that we think is beneficial to the system at large. So there may be thoughts on that, but maybe I'll briefly just go to this table that we created to try to represent that. And I think what's most important here is the distinction between non-critical access hospitals, and I'm using financially stable here, and critical access or financially vulnerable hospitals, just to indicate, you know, that difference that caps on how much can be charged at a service level is where that will not apply to critical access hospitals or financially vulnerable hospitals, but the cap on the growth of prices would apply to all hospitals under the structure that we envision. And likewise, there's sort of an important distinction between fully insured plans and then self-insured plans, because the state is able to, you know, I think for fully insured plans, we would anticipate kind of just mandating both the kind of participation where we would require them to comply with floors on primary care and behavioral health care, and also prior authorization reforms, because we're not able to do that for the self-insured plans. That's where this opt-in or opt-out component comes in, where we would want to see participation in the floors and compliance with prior authorization requirements in order for them to sort of have the ability to access caps on hospital charges. So if self-insured employer plan sponsors don't want to be able to do that, then they could be charged above the cap on hospital services. So I know it's a lot going on. We're still working through. It's a complex series of kind of components of this legislation, but trying to find ways to make it maybe a little bit more digestible. And then in terms of establishing the level of caps and floors, again, we've talked a little bit about this, but I think good to spend a minute on the work that's actually going into that. So we've been working with Wakely, an actuarial firm that's part of Health Management Associates, on a repricing of 1 year worth of commercial claims from the All Fair Claims database that MHDO maintains, and taking that entire set of claims and sort of working through essentially a proprietary algorithm that they have, for lack of, I'm sure there's more technical terms Katie could use, but they have code and again have some really great experts in particularly kind of Medicare payment structures to reprice claims to the amount that Medicare would have paid. So that's where they're essentially doing DRG or APC grouping of claims on the commercial side and then creating the equivalent Medicare payment to make the comparison. That will allow us to estimate the Medicare relative rate for commercial claims at the claim level for each main hospital, estimate the amount of avoided spending or savings. I've used the term savings in the past that would occur under different service level price caps at each main hospital. So we're looking to do kind of a sensitivity analysis here with a range of cap levels to understand what the different avoided spending amounts would look like under different levels of caps, and then estimate the amount of additional spending that would occur under different levels of service price floors. So going through a similar process with all claims for primary care and behavioral health services, using those set of codes that we help them develop, again, really focused on E&M, preventive care and counseling, to similarly look at what would different levels of investment look like and what would sort of be the cost essentially associated with those components. So that's sort of step one, to really create a baseline for ourselves of what spending has looked like and what different benchmarks would look like in terms of just changes in spending on those services. And then the next step is working with the Urban Institute using their health insurance policy simulation model, which folks may remember was used a couple of years ago when the office was still relatively new, to help develop kind of a baseline estimate of where costs and coverage were in Maine. It's one of the few policy simulation models available to states, so we're excited to have access to that. And really that takes those savings amount and kind of translates it into what the policy impact is. So quantifying kind of overall changes in spending over time and under the different cap and floor scenarios, but then really importantly, estimating what the impact of the policy is on individuals and employers. So, we know in the self-insured market, potentially it's easier to understand what avoided claims look like, but what that means for employee premiums, for example, or employee contributions to their coverage is important. And then in the fully insured market, really important to think about what could changes like this look like mean over time in terms of what individuals are actually paying out of pocket for their health insurance. So that's sort of the secondary analysis that really gives the fuller picture of what the impact of the policy is. So again, we understand that's really important and obviously is a key component, I think, to determining what the right level of a cap could be. So we're working hard, folks are working hard to turn that around, and we hope to have it in hand soon, but it is underway. Is there anything I missed on that, Katie?
No,
Or the expert on that? Okay, thank you. And then I also wanted to revisit the conversation about changes to prior authorization. I mentioned this again as something that we've had an interest in because we hear about it from providers and from patients. And we've talked about it a few different times at our meetings, but I think we wanted to make another request for feedback on this. You sort of thought about a very baseline version of this looking like requiring self-insured plans to comply with the requirements or the limitations on prior authorization that already exist in Maine statute for fully insured plans. But we're interested in going beyond that potentially as well, and trying to think about especially this point of intersection maybe where there's prior authorization used, but approval of prior authorization is very high. Places where it seems like potentially this is administrative work on both sides for payers and for providers that's not doing a lot to improve care, not doing a lot to generate meaningful and important savings for consumers. So I wanted to pause there. I know, Katie, back in our September meeting, I think you had said that you had some feedback on this and that you were thinking about going back to your team and getting a little bit more information about particular changes that you'd be interested in seeing to prior authorization, or maybe services where you saw a lot of volume of PA requests and a lot of approval. So did just want to check and see if that was something you'd had a chance to talk with folks about, and if you had any other feedback or input on this.
Thanks, Meg. This is something that our team is very interested in. We've been running some data on it, and I don't have the data available today, but there is a bill pending that is on the Appropriations Committee table that would take the next step, which it was developed by our team, but it's based on prior authorizations that are being required for medications for chronic conditions. And it really is just kind of a no-brainer for many of our, certainly for our providers and our patients. So these are patients with chronic conditions who are being required to go through frequent prior authorizations by I should be clear, not all carriers, by some carriers more than others. And it would change the time frame. It would set a time frame through which they would have to go through those PAs. So that's legislation that's already out there that we obviously strongly support. That would be a good place to start. And there are lots of other opportunities, but that's a big one.
Got it. Thanks. Yeah, that's helpful feedback. And we have taken a look at that. I know, trying to think off the top of my head, I do remember there was a fiscal on that was pretty considerable for additional costs to the state employee health plan, I think.
Well, and I think that explains exactly what the problem is from our perspective. The fact that there is a fiscal note associated with providing a reasonable time frame for prior auths for individuals who have chronic conditions, who are on these medications for years, it really does reflect the frustration and challenges that our patients and our providers are facing, because these are not brand new drugs that are costing $1 million a year. These tend to be very sort of the stable, long-term kinds of medications that people have been on for a long time. So I think there's just the fact that there is that fiscal note really reflects a big piece of the problem that we're experiencing.
And just to confirm my own recollection, when you say time frame, I think that was focused on length of validity of the prior authorization, not time frame for decision making. Okay,
no, that's correct. It was I think a year that we ended up. I'm trying to remember the specifics of where it ended up, but it was to allow for a prescription to be for a year. I think we started at 3 years, but I will have to confirm that.
Kevin, I'm reading your comment. I don't know if you want to share that out loud or happy to.
Yeah,
digest.
sure.
It's a big.
Sure. I didn't get to it fast enough when you were talking earlier about the Wakely and the analysis contemplated, but wondering if, as part of that, there's an effort to look at ambulatory sensitive conditions, and those ACSCs were sort of at the top of everyone's thinking years ago, and to some extent it's kind of fallen out of, I don't want to say out of favor, but it's not necessarily in focus as much today. But it seems like it's the other side of the coin with the alternative payment methodologies, and necessary to look at, what particular conditions, treatments, services are driving some of that cost of late. For instance, we have sepsis claims that run $500,000, and what can we do collectively? Sometimes these things just happen, and I get that. We see that all the time. But are there instances and ways that we can work collectively to stem the tide of some of those costs? And we won't be able to cure it all, but if there are enough of those within the new payment methodology, we can really start to take a whack on the total costs without becoming a zero-sum game.
Yeah, and I would say, at least in my mind, that's an opportunity that falls potentially most within maybe that rural health transformation program work. Again, I know focus there is rural, but given the nature of our state, I think that there's going to be a lot of kind of breadth there to think more broadly about care delivery all around kind of all geographies. I think, again, in thinking about this proposal specifically, the analysis that we're doing is really kind of focused on just prior claims and repricing, and to some extent an assumption of not significant changes in payment models. But again, I don't think it closes the door necessarily on those kind of ideas. But I think it takes time and work to get there. And I think our concern is we're sort of on a trajectory now where we really need to more quickly kind of turn the tide, or at least set some kind of limitations and like a reasonable corridor for how we move forward, just to sort of stabilize things as we think about some of those bigger ideas. And appreciate the note on PAs. I think that that's great feedback. And again, I think that's where we continue to feel like there's opportunity in that area, where there is a lot of like shared interest maybe in ways that there aren't on a lot of other issues. And I think an area where just maybe kind of market dynamics and other factors we want to be mindful of, are there kind of places where there's a best practice, but it's hard to move as a carrier in that direction if others aren't moving that way too? And are there ways that we can maybe pick up good works that folks might be doing individually or thinking about, or take understandings from kind of cost benefit analysis and say there's a good body of evidence here. This is really something that everybody should be thinking about. Appreciate that, but I think sometimes the fragmentation can be hard with different policies across different carriers and maybe different philosophies or approaches to that issue.
Yeah, I mean, we certainly, look at prior authorization not as a means to, deny for purposes of denial, but rather look at it as a communication channel that ideally guides right care, right time, right place, and it's all about what does the patient, what does the member need. So it's that communication with the provider that we find essential, and if that's not working, then we need to improve on our side and find ways that communication can work.
Are there any other thoughts on this prior authorization piece, I guess, in particular from any other advisory council members? I just want to, again, make sure that we're putting the ask out there because we appreciate the feedback. This is, I think I've said before, I think a particularly difficult issue to look at literature on, for example, because there's variation across services. So sometimes you can find, some good studies and papers that look at application of prior authorization in a particular circumstance, but there's the body of evidence about cost and benefit is really mixed and not strong on this. And it's also, I think one of the areas where visibility into policies and practices can be really challenging as well, like getting a sense of where variation is and what are the practices that are most, challenging for folks, because a lot of the time I think it can devolve into just kind of two camps. So appreciate any feedback on this, like I said, from folks with a little bit more on the ground experience. Yeah, Randy?
Yeah, obviously I don't have anything today, but I'd like to talk to some of the people that do this on a daily basis. And what would be the forum in which to get you some information back when I have that conversation? Is this just an email or wait till the next meeting? I just want to make sure I am timely getting back on this conversation.
Yeah, I would say if you're willing to share something via email, that would be great. This is something that we're, looking for feedback on to kind of incorporate into the proposal, which we are anticipating may be considered by the legislature this session. So an email would be great, or if it's easier, we're happy to hop on the phone too if there's some folks on your side that would want to just have more of an informal conversation about that. We'd be happy to chat. I think, if broadly folks want to find time for everyone together, happy to do that. But I know we struggle to find ad hoc time because this is such a busy group and wouldn't want to wait all the way until the next meeting to discuss again.
Okay, perfect. Thank you.
Thank you. Okay, I think that was my final slide, but I know folks may have other comments, questions, so maybe I'll pull the slides down for now and have that conversation, but I can always bring them back up if it's helpful for you. Yeah.
Thanks, Megan. And I will definitely, I appreciate your request for feedback on, maybe it's not just prior authorization, but opportunities to address regulatory / administrative costs that providers, I guess in this case, it's just hospitals, are incurring because they are substantial. I wanted to raise the question, since the office is putting forth legislation that we have not seen, is there an opportunity for you to send a draft of whatever is available out to us in the next, coming days? And I do, because this is an advisory council that is viewed as being an important part of the work of the office. I guess this is really for the chairs as opposed to potentially for the staff. But I do think that it would be helpful to have a vote prior to the presentation of legislation that is being put forth by the office. I would think that the office actually might want such a vote in order to show support for the legislation that they're putting forth. But it does seem, from a governance perspective, important because this is really a key output of this office. So I would ask Trevor and Kate if you could weigh in on that and what your thoughts are related to that.
Are they on? I thought I saw Kate on.
They were both on at some point
and dropped off. I don't think we have either of them right now, but they were
okay.
On here.
All right.
They might be testifying, but yeah, if you either want to check in with them directly, Katie, or I'm happy to follow up. And I'm not at all, again, more a decision for them, but I will say from my perspective, I don't disagree at all. I think we're always challenged by timelines here. And again, the challenges of sort of bringing everyone together and figuring out how a legislative process and some of the, changing expectations or requests of us from the legislature kind of fit in with our opportunities to check in. But I would think that, potentially there could be an opportunity to do that in writing via email or call an ad hoc meeting as things fall, when we sort of have something more firm for people to respond to. So
yeah, I would appreciate that. I think it would be preferable to having surprises or having it all just be before the legislature without having something formal from the council first. So that would be helpful. And is there, with the last legislation, we did not receive a copy of it in advance. Is there an opportunity to receive a draft in advance?
I will do my best. I mean, I thought we did share.
We did share.
Oversight. Yeah, but glad to try and do that again. It's like always the difficulty is that things are moving, and I hesitate to share something that the revisor's office hasn't looked at, but we will do our best to get something out to folks sooner rather than later. I think that we're expecting something back hopefully pretty soon. So we will do our best to share, but again, also want to be careful that we're not sharing something that looks different than what an eventual product will be. So
thank you. I appreciate that.
Mm-hmm. Any other feedback issues? The one other thing I realized I didn't put on the agenda, but just wanted to mention, we'd share the annual report for the office with folks as usual. As I've said in the past, that's largely, I think, material that should look familiar from our advisory council meetings. over the last year, but with the one exception being, we did put a little bit of information in about Rural Health Transformation Program, which we haven't had a chance to share yet, but now have. So we'd ask, if possible for folks to share comments if you have those by kind of end of day on Friday, but also acknowledge, if anyone needs a little bit more time, let us know, but looking to finalize that and send that over to the legislature soon. A note there, and if anyone doesn't have that in their inbox, we'll say, Amanda, I see that you're on now. A heads up, no need for you to necessarily review, but you won't have it, but I will send it over to you after this in case you'd like to take a look. Last call. Oh, hi, Amanda, nice to see you. And I think you weren't on at the very top, and I will just say I had shared with this group because we do have folks who aren't here yet, including our chair and our vice chair, because they're over with the legislature. We're going to hopefully find time at the next meeting to do more of a round of introductions. But glad you're able to listen in for today's meeting and get a little bit of an update. But we'll do a level set next time. All right. Well, if there aren't any other items, I'm happy to let folks go a little early. Thank you all for managing to join us today with the weather. I know it wasn't always easy, so really appreciate it. And we will be in touch on next steps, including kind of process-wise about opportunities to more formally weigh in and draft legislation when we've got that in hand. Thank you all. Bye-bye.